Welcome to the next episode of the 20-Minute Clinic. My name's Robert Westgate, and it's a pleasure to have in the studio this afternoon Dr Marcus Rieborn. Hello, Marcus.
Hello, good afternoon.
And as ever, Paul on wires and leads and all things technical. Marcus, would you just tell us and the audience just a bit about yourself?
Sure.
And your journey into general practice from training up to what you're doing now?
By all means, I'm a GP in Brampton, one of the partners there. I've been there for 8 years now, coming up 8 years. Prior to that, I was GP partner in Carlisle Healthcare for about 2 years, I think it was, right at the very start. Before that was a GP partner at St Paul's, which was my first ever training practice, where I was a GP trainee under Dr Rieborn, who I don't know whether you've interviewed on here or not.
He's been on. Yep.
He was my trainer many years ago. So I moved up here 20-something years ago now, trained in Sheffield. My wife's from Hexham, so we moved up to the north. She was working up here, slightly unplanned in many respects. We were looking for a job, and to be perfectly honest with you, didn't even know where Carlisle was. I thought Penrith was in Wales because it sounds like a Welsh name.
It really does.
Doesn't it?
Yeah.
And Carlisle, I mean, how many people have got the train to Cardiff by accident?
No, well, bearing in mind, I'm from Tamworth, so I'm a Midlander. So to me, Sheffield, where I went to university, was north. So now when I get friends and family coming up to see me and I tell them, well, once you get to Preston, you're halfway, they then say, why the hell are you all the way up there?
So did you manage to survive the rail replacement service and end up in Carlisle?
Well, yeah, so I was actually looking for a job in Newcastle, and all the jobs were gone in Newcastle when I applied. And I actually happened to, so as I say, my wife's from Hexham, happened to look on a map, old-fashioned map, not one on a phone, and went, ooh, Hexham's in the middle. Newcastle's one side, I'll give Carlisle a ring. So I did. Pretty much offered me a job. Obviously, getting newly qualified doctors, particularly GPs, into Cumbria has always been very difficult. Did my junior house officer roles in the infirmary and never left.
So what was it about general practice that made you want to train to be a GP?
Different doctors do sort of have different career paths, I guess. You get people who have always wanted to be a doctor all their lives. That's all they've ever known. Never wanted to do anything otherwise. That wasn't me, I'm afraid. I wanted to be a vet. Went down the veterinary medicine route. Unfortunately, whilst I got a place at the Royal College of Vets in London, didn't get the grades to go to it. And at that time, there was only 6 unis in the country, so it was, you were talking sort of 300 applicants to one post. It was pretty heavy duty to get in. Then had a bit of a quandary, what do I do? Had a scoot around a few different ideas. I knew I wanted to do a vocational degree. I didn't know what necessarily. Kind of stumbled into medicine as a result. Went and spoke to a few deans at universities to try to work out what I needed to do to get into uni, because obviously I'd already got my grades at that point at A level, but I hadn't got any work experience whatsoever. And they essentially, the guy at Sheffield that I went to see essentially said, well, look, academically fine, not a problem, but show us you want to do it. So I then spent 12 months working in a care home as a healthcare assistant, and that was enough, amongst other things, thankfully, to get me into med school. I was very, very lucky. I had an absolutely amazing tutor at university, a guy by the name of Steve Peters. Steve is the guy behind Chimp Theory.
Oh, yes.
I think he did an awful lot with Dave Brailsford and the British cycling teams. Certainly I know Ronnie O'Sullivan, spent a lot of time with him, so we did an awful lot of helping them with sports psychology way back when it wasn't really necessarily a thing. So for a pretty lengthy period of time I wanted to be a psychiatrist, because I think we're often shaped by the people that influence us. There was a couple of other thoughts. I thought about doing urology and possibly upper GI surgery, so I tended to go down more the surgical route than medicine. Why general practice? I discovered that whilst I'm not necessarily the brightest spark in that the theoretical stuff maybe isn't where my forte was, but talking to people seems to be something I'm not too bad at. You might disagree after this. I just have found, as a result of what we do, our job's quite a privileged one. I'm sure other people would have said similar things, but the fact that we are trusted by, quite honestly, strangers who know us but we don't know them, they know us by maybe name, by sight, whatever, will come in and sit down and in the space of 10-15 minutes have told you some of their most innermost thoughts, their deepest secrets, their biggest troubles, some of their greatest achievements. To have them share that with you is quite special, really. And I think it's probably something that we're starting to lose for one reason or another, maybe as we're progressing through medicine over the last 10 years or so. Certainly when I started, that was very much something that was sort of continuity and cradle to grave care and sort of following families through seemed easier. At that point, it feels almost over the last 10 years, trying to maintain that has been harder and harder to do. So I ended up doing general practice.
Obviously, you came up to Carlisle to do your junior doctor jobs, and you've stayed in Carlisle or in and around Carlisle for quite a lot of years. What was it about working in and around Carlisle that made you think, I want to stay here, I want to settle here, I want to develop my career here?
I will have been early 20s. I was kind of already in the route of sort of planning. I knew when I qualified that I wanted to do general practice. Once I'd settled on the idea of doing general practice, I knew I wanted to work in a practice. I wanted to be a salaried GP for a couple of years to actually learn my craft. I think that's possibly something that generations prior to me didn't always do. You pretty much qualified and went straight into being a partner. Now it seems to have swung the other way, and that partnerships seems to be less of an option for people. They want to come out and do more of a 9-to-5 job, which is tricky because general practice medicine isn't necessarily always a 9-to-5 job. It doesn't sort of lend itself overly well to that. But I knew that I wanted to learn my craft for a couple of years before I went into partnership. And in my mind, I'd kind of got a roadmap in my head of what I wanted to do, getting married, children, so on and so forth. So part of that was very much a reason for staying around here. A, it was affordable. And B, as I said, I'm kind of from the Midlands, although I've not been there for a long time. Bringing a teenager up here is different than what I see some of my friends back home having to sort of cope with. Plus you've got beautiful countryside, the lakes is only half an hour away, although we never go anywhere near as much as we should do considering they're as close as they are. And the northeast stunning. And so the south of Scotland, there's an awful lot of stuff around about us. We're only an hour and a half away from Newcastle, a couple of hours from Manchester, Glasgow.
One of the things you've mentioned as a theme is the importance of relationships. So thinking back to being an undergraduate and your relationship with tutor, you mentioned your GP trainer when you're trained to be a GP and the importance there. And I suspect some of the relationships, professional patient relationships you had as a junior doctor were also important. And I guess it's relationship, that's the essence of general practice, isn't it? And you hinted at it earlier in terms of longitudinal care, cradle to grave care, and getting to know someone throughout their sort of life history and then applying that in terms of how you interact with them.
And we're part of a community. I think sometimes as well we forget that we're part of the community. I'm lucky I live in the community that I work in. And I guess that's a double-edged sword in some respects, in that I'm not available 24/7 for people to knock on the door or send me a message asking me their advice. But at the same time, I see people around me. I like the fact that, you said earlier, why Carlisle? Why stay here? I like the fact that it's a small community. I like the fact that it's a community that knows each other. Some of my friends from home, they don't know their next door neighbours. They've lived next door to each other for 10, 15 years and barely speak to them. I know the people that I live near. I know the people that I work with. I went to see somebody. I had an appointment early before the podcast. I went into the shop and the person that I was talking to remembered me from looking after their child 20 years ago. It's quite a powerful thing to think that quite clearly something I did, hopefully for good, influenced them all that time ago, that they still remember me, even though I've had very little to do with them ever since. I had a couple of episodes last week where I had patients coming in, patients of mine from St Paul's days, who came in with another relative, and it was like it was very strange seeing people in a different setting. We're privileged that we get that, to have that conversation about their child who was 2 when I saw them, who's now coming up 21, and we work our way through. And that for me was the essence of general practice, that developing a relationship not just with one person, and not one person based on their disease or their syndrome or their illness or the number that they happen to be on a piece of paper, but them as a person. I think that's quite a powerful thing. I think that sometimes is something that we forget, as I say, in this current era where everything seems to be very much focused on access, and we have to get people in a certain amount of time, and it all is about demand and urgency. And actually, unfortunately, I think what we lose in that, because we can't be all things to all people, we lose the ability to have that continuity of care to some extent. That if you were to ask any patient and any doctor, all of us would turn around and say is absolutely crucial and critical to what we do and to the relationship that patient has, and the service that patient has, and the service that we deliver as a doctor. It's crucial, but it's really difficult to try to maintain when people on much higher pay grades than you or I have a completely different route that they've decided the country needs to go down. It's very tricky.
Because access to general practice, it's really important, isn't it? But continuity of care and relationship within general practice adds quality, adds value, and adds tangible benefits in terms of
improved outcomes.
Improved outcomes.
Yeah,
that's right.
Yeah.
So
it's evidence-based.
Reduce utilisation of A&E, reduce referrals to
Absolutely.
outpatients, greater clinician and patient satisfaction, and reduced all-cause mortality. And that shouldn't be trumped by the importance of having an accessible service.
No.
And when there isn't quite enough to go around, or as much to go around as we'd want, the tensions between access and relational care sit in a very, very difficult relationship themselves. And I think as people providing the service or running the business that provides the service, it makes it really hard for us to get that juxtaposition of offer correct.
Even if you just sort of break it down into very, very simple terms, if you've got somebody coming to see you for the second, third, fourth time, whatever, and if this is a progression of a chronic illness they have, or even sometimes an acute illness that they've had. Say Joe Bloggs came to see me last week with their chest infection and explained to me what was going on with their chest and how long they'd had it for and what they thought might have brought it on and so on and so forth. And then they come back and see me this week and it's not any better. Well, I don't need them to go through everything that they went through and told me last week, and they don't feel they need to go through that. If I'd not met them and this was the second time they'd come in to see somebody, then often patients will get very frustrated, understandably so. Well, I'm having to say the same story again. And that will often be followed by, well, do you not have my notes? Absolutely, I've got your notes in front of me. But that's what somebody else has written and somebody else's interpretation of that. And actually me getting my own idea and understanding from what you're telling me. And there may be things that you didn't think about, that you didn't remember to say, that the person that was sitting there listening to you last time didn't pick up on. We're always interpreting, and I think depression is one of the most difficult consultations to do with somebody, because you're trying to, as a doctor, as a clinician, you're trying to interpret somebody's emotion and you're trying to get an understanding of how they feel based on words or based on a feeling that they're trying to put into words that they maybe don't quite know how to put into words. And you're trying to sort of decode and decipher something that they don't know what the cipher is to do that. And again, having that relationship with people, seeing them more consistently with their same clinician, makes that whole process a lot easier.
One of the things we were talking about before we went on air was the number of GP vacancies in Cumbria, in North Cumbria at the moment. I'm really excited about the developments with Pearse Cumbria School of Medicine, which went live with its first intake in August last year.
Yeah.
Some of the language that's used around the medical school and one of the sort of principles behind it is about training people to be doctors who are going to be sticky doctors in the area. So people who have a positive training experience both at university and on placement, and then choose to stay, choose to do their postgraduate training in medicine and choose to work locally. And what you've described, Marcus, you're a really good example of a sticky doctor. So you've worked locally. Obviously, your medical school is further afield, but you've done your junior doctor jobs locally, your GP training locally, and several years down the line, you're working as a GP partner just outside Carlisle. Looking back, what is it that's helped you to be a sticky doctor, to want to stay where you've trained, to work where you've trained, and to sort of settle where you've trained?
I think I alluded to a couple of things earlier on. First off, it's very affordable compared to the rest of the country. I think being affordable is very important around here. I do. The fact that the price of housing is reasonable, certainly when you compare properties that you would get, say, in a big conurbation, Newcastle, Birmingham, even if you go over to Hexham, the price of a house is £150,000 for a similar sort of sized house to over here. I think that's a big benefit. It means that you've then got a degree more of disposable income. I absolutely love the people, to be honest. I genuinely couldn't imagine living anywhere else again now. I think I've probably developed a bit of an aversion to living in a big city, but that's because I've been such a long time since I did.
Is that something about community?
Massively
and
so.
Feeling welcomed by the natural communities that we live in and that we work in?
Yeah, I think I said earlier on, friends of mine don't know their neighbours, don't speak to their neighbours, and they've lived next door to each other for 15, 20 years. Yet you are very much part of a community in Cumbria. Carlisle's not a city, it's a village. And when you've worked here for some time, you'll realise that most people either are married, related, or best friends with somebody that you know that you're speaking to, whether that be on this side of town or the other side of town, more or less. And that sense of community, that sense of togetherness, kids these days will spend all day looking at their phone talking to their friends rather than talking to their friends. And I think that is really, really important. And the only times we really seem to see it elsewhere in the country is for jubilees or special occasions, and yet that's something that happens in most villages around about Cumbria on a regular basis.
And like you were saying, the bigger cities are just down the road. It's not like you're completely isolated in the sticks.
That's right. And just because you might choose to have a leather elbow patch on your jacket doesn't mean that you're isolated from the rest of society in the UK.
Not at all. No, not in the slightest. I think certainly that was something that COVID maybe taught us as a country a little bit more as well, that because everybody was working from home, actually we maybe don't have quite, or didn't have quite, the fibre network that seems to be developing as we're going on at the moment. But internet connections aren't bad anymore, so people can work from home far more easily than they ever used to, which brings a whole raft of other jobs, not medicine particularly, but a raft of other jobs. And don't forget, most medics have usually got another half. There's usually some other partner, person, husband, wife, whoever it is, and yes, some of those will be in the medical profession as well, but an awful lot of them aren't. So you have to try to cater for both. I think schooling is much better than a lot of people give it credit for, or gave it credit for locally. So bringing up a family, I've got a 13-year-old who's at school locally. It's brilliant, very happy there. Big school, but doesn't matter. And why wouldn't you want to stay around here, wouldn't you here?
That's a really good answer. You know, why stick here?
The weather.
Or why wouldn't
that
you?
Would be the
why
reason.
Wouldn't you?
Only the weather. Grey and drizzle, but apart from grey and drizzle.
It's fair. I was just thinking about the fibre reference, and it's not that many years ago fibre would be an adjunct to positive gut health, and now it's all about digital connections. How things change. I was going to just move slightly into neighbourhoods. Just think about community, neighbourhood health, the next new thing for the NHS. But have we sort of done it before? General practice, the small business or multi-size business provider working within the NHS but kind of separate from the NHS. Neighbourhood health, how do you see the future of that sort of developing, say locally or within the sort of national picture, and where does general practice fit in?
I think general practice has to be pretty integral. The difficulty that we've got at the moment is we don't necessarily know, and I'm not sure. The devil will be in the detail with a lot of things that we're as yet to see. The ideas are there, thinking about different ways of working and having less of a hospital-based system, more of a treating in the community-based system. Pretty sure we did something like that 20 odd years ago. But having a look to moving that shift out of secondary care, so hospitals, more into a community base. It's very difficult to see how you can't do that with general practice, in my opinion. As I said, we know our patients' families, we know the dynamics. And North Cumbria is a very challenging geography. You mentioned about neighbourhood teams. Things are going to be changing. PCN, so primary care networks. There's an urban element to that, and then you've got the vast rurality that we bring with my practice. But you've got little spots of that all the way across the whole of North Cumbria. Somewhere like Manchester, Birmingham, London, you might have a whole primary care network or neighbourhood network that's maybe only got a sort of radius of a mile, and everything's kept within that, and their population density far surpasses the entirety of North Cumbria, and yet we've got all the way across from Egremont to Gilsland in the east, or up to the borders, and then down as far down as Kendal, really. I mean, it's a vast area. So trying to get one thing that fits everything is very, very difficult. And trying to provide that for everybody is really tough, which makes that shift from secondary care to community care far more sensible. I think we've probably always kind of done that here without necessarily it being recognised. I think we've always tried as an area to do the best for our patients, to try to go above and beyond things that maybe we shouldn't be doing contractually but have tried to do for the betterment of our patients, because I really don't want you having to drive all the way to wherever it may be. Unfortunately, we also are private business owners, so we have to make sure that there is a profit at the end of the day, otherwise the business isn't viable. And if the business isn't viable, then sadly, unlike any other private business where if your costs go up, you invariably end up passing that on to the consumer. We can't do that. We aren't able to do that. Our costs go up. The money that we get that comes into the practice is pretty stagnant and has been for a number of years. So trying to meet that demand is tricky. The neighbourhood networks thing is an idea to try to help move that care away and have it more, the ultimate idea to that would be a sort of neighbourhood health centre where you'd have everybody in one building, health visitors, midwives, doctors, nurses, pharmacists, whoever. All based, district nurses, all based in that same building. As I say, a bit like we used to have when I was growing up. And everybody all working together to one sort of common aim, which is great if it can be practicably done. It's a challenge.
I think it's really challenging. One of the things that I think is really important is that list-based care, or general practice, largely as we know it, is the foundation to build on for neighbourhood health system. So you mentioned a number of other organisations that we work alongside. Along with that, I would look at broader community assets and third
Absolutely,
sector, and
100%.
just trying to harness all the opportunities and energies that people bring.
And people often expect us as a GP to know all of the other facilities and services that are available in the community. We've got such a varied and vast array of different things in my practice area that actually, as terrible as it sounds to say, I can't remember all of them. I just don't have all of that information to my fingertips. So we've got within my practice care coordinators who do have a much better grasp of that. And some of these services are absolutely phenomenal. And I think one of the biggest challenges for our older populations is actually loneliness. Having befriending services, there's a new one started in Brampton through the community centre, which sounds fantastic. And it's going to enable people who are later in life, who maybe live on their own for whatever reason, who can spend a week not actually speaking to anybody other than possibly the doctor when they phone up for something that may or may not be health related, but it's a point of contact to talk to someone. And actually loneliness is the issue, and not having people to talk to, not having somebody to bounce an idea off. The third sector, it's a voluntary sector, charitable work, there's a massive part to contribute to that.
One of the things that came to mind when we were talking about sort of balancing the books and running general practice was the Lord Darcy report from 2024, which recognised that general practice, English general practice, UK general practice, is the most cost-efficient part of the NHS in the system. And we shouldn't forget about that in terms of investment into general practice reaps significant rewards.
It does.
Into both financial rewards in terms of value, but also the health benefits of, if we get the portion of doctors to patients correct, we actually deliver high quality continuity of care and reap the benefits that we know that should deliver.
Absolutely. And outcomes are proven on that basis to improve for everybody. Better satisfaction for patients, better working conditions for doctors. And what I mean by working conditions for doctors is actually the enjoyment of the job is what I'm referring to on there. And having that satisfaction that you've done a good job at the end of the day, that you've helped somebody, that you've listened to somebody in a time where they need it. That's where the satisfaction comes from this job. It really does.
And there's something there, Marcus, as well as thinking about GP recruitment, about describing the job that a newly qualified GP would want to do.
Absolutely.
So they can work safely, they can work at a rate that delivers quality, they can feel supported in that role, and then choose to stay, to settle, and contribute to the workforce going forward.
Yeah, entirely. When I got into general practice, it was roughly something like one whole-time equivalent doctor. So what I mean by a whole-time equivalent doctor, for those that don't know, is that is essentially one person working 5 days a week. Now, most of us don't work that, and for a variety of different reasons. A lot of people might say, well, there's your problem, you haven't got enough doctors working full-time. I work full-time, I work more hours than I'm paid to work, just because I do. And that's just the way, because in order to do the job that I want to do, I need to do that. But when we're measuring a whole-time equivalent, we're actually looking at the number of patients per full-time, per five days a week of doctor. And when I started 20 years ago, you were talking roughly about 1,500 patients per whole-time equivalent. Now in certain parts of our county, you're talking 2,500 plus. That's a lot more people. Historically, patients had roughly 3 contacts per year with a doctor's surgery, and now you're talking 7, 8, 9, 10 plus. Not only is the number of patients per doctor much higher, but the number of times that they need to get in touch with the doctor is also much higher as well. It makes it very challenging to sustain.
That's right, and a significant increase in the intensity of contact, the frequency of contact, and the number of patients per whole-time equivalent doctor, which I think in the UK average or England average is probably around about 2,700 at the moment. I think there's a national BMA target for 2040 to get that down to 1,000 patients per whole-time equivalent doctor. Very, very ambitious, but imagine the quality of continuity of care that could be delivered with those ratios.
It'd be amazing, but then you're talking about tripling the workforce. And with the best will in the world, in order to triple the workforce, you have to fund to triple the workforce. Bad news sells newspapers, and it's quite interesting when you see that various articles are sort of saying there's this doctor's crisis and there's all these unemployed doctors, GPs, whoever, and no jobs for them. But that's because there hasn't been any substantial increase in money in order to employ those doctors. The money's just not there. It's the same money that we had, by and large, about 10 years ago. So to try to employ more people, it's nigh impossible.
Because we're at an interesting time, aren't we, where there's a lot of threat about being able to deliver the service that we would want to deliver, or if we're on the receiving side.
I think there's an awful lot of good things going on in Cumbria.
Uh-huh.
And I think there've been an awful lot of good things going on in Cumbria at local level across the patch for many years. I think sometimes those things aren't necessarily recognised. I think sometimes those things then don't become a universal standard because they don't work in other places, I guess. But I think the most promising part of Cumbria is the people, as I said. I think the people that live here are what make Cumbria Cumbria. And their stoicism, their determination is really, really important in trying to drive things forward. I don't think I'll ever be considered Cumbrian. I don't know my son will ever be considered Cumbrian because I'm nowhere near and never been born here, although he was. But we're still interlopers. But in some places, you very much feel like an interloper. You're not from that area, whereas I've never felt that here. Really haven't. It's a great place to live. Great place to live, great place to work, great people.
I think our 20-minute clinic appointment time is almost over, but there's just one question to finish off with. So if there's one thing that you could change in the NHS that would make a difference to what you do and to those around you, what would it be?
I think I would like to sit down and have a conversation with ministers for health and actually have them sit with me, with colleagues on the shop floor to get an understanding about what we actually do. I think one of the biggest problems that we've got is there a perception by politicians that they understand what we do because think tanks tell them they understand what we do, without them necessarily having a grasp of what any of us do, be that in hospital or general practice or any other health sector. I guess it's kind of, that adage that the Queen thought everywhere smelled of wet paint because every time she went somewhere new, they'd just painted it. And I think there's a lot to be said for that. I'm not entirely sure that the people who sometimes make policies and make changes to agendas are quite as understanding as they may put on.
So there's something around the policymakers to better understand the realities of general practice.
I think so. I think that would make my life easier. I think if I didn't feel like it was constantly a battle, trying to stay still, trying to do my best for my patients, because ultimately that's why I'm doing it.
Dr. Marcus Rieborn, Paul, thank you very much.
Thank you very much.